I'm Ryan O'Connor. I'm the optometrist at Ashburton Eyecare, and we're going to go through a webinar tonight talking about the aspects in which way Ashburton Eyecare are protecting your children's vision. This is about understanding myopia or short-sightedness with Ashburton Eyecare, who are your children's eye health experts. So, as I said, we're talking about the management of myopia. It's short-sightedness or nearsightedness, which means that it's hard to see things in the distance. Now, of course, for children, that means seeing the board, playing sport well, and lots of things. As they get into teenagers, it becomes being able to drive. And then through adulthood, of course, being able to enjoy the world around you. By that stage, I would hope that the myopia has been voiced and taken care of, and you can see. But we want to talk about the key problems here, in that being myopic and having your eye grow more rapidly increases the risk of serious eye problems later in life. And for many people, that level of increased risk is quite alarming, that not many people know. So that's what the purpose of this webinar is all about. So as I was saying, it's when the eye grows too long, and that means that when looking in the distance, the image is focused in front of the retina, and so then it's blurry for the retina. It's quite common, and it's becoming more and more common. In fact, by the time we reach 2050, it's estimated that half of the world is going to be short-sighted. And as we go through the stats on that, it becomes quite harrowing that this is a big deal, and why you'll hear more and more about myopia and myopia control as time goes by, if you haven't already. The reason why we're doing it on the end of September is this month was Myopia Action Month by the awesome team over in Australia, My Kids Vision and Myopia Profile. Dr. Kate Gifford has put into action the Myopia Action Month. And My Kids Vision is an absolutely sensational resource if you're looking to understand myopia, to look at your own risk factors, and also another great website is the Brian Holden Vision Screener, where you can look at the risk profiles and get a little bit of a range of how long your child's eye might grow based on their outdoor time, based on their current prescription, based on your prescription, your partner's or the child's other parents' prescription, and the various ways that we can treat myopia and slow that down. So yeah, Kate, of course, being in Australia, has a bit to do with the Brian Holden Vision Foundation's calculations, and yeah, there's heaps of resources. And so being Myopia Action Month, and this becoming more and more important, of late I've been through a lot of webinars and CPD, continued professional developments on myopia. But for me, my journey started in optometry school, where I did a summer studentship, and we were looking at a chick model of myopia and looking at the effect of light in slowing myopia. And for many of us, and that's why for me here in Ashburton and where I previously was in Taupo, I think I don't actually see the 50% levels of myopia that some of the cities have in New Zealand, because we're quite lucky in this part of the world, in the Canterbury, that we have these beautiful, expansive countryside, and lots of people get out there and enjoy it. So therefore, the numbers of myopia aren't quite there. But as we know, the demographics of Ashburton are changing, particularly those with Asian heritage who are more at risk. And so more and more we are seeing people in primary school and moving through intermediate and high school with glasses on and needing increasing prescriptions, and that's a reflection of that rapid eye growth that happens. So an awareness of the significance of that is huge. So like I said there, more powerful refractive correction, greater risk of glaucoma, greater risk of maculopathy, which is where your central detail vision happens. So if that's being damaged, you lose the ability for central detail vision. Retinal detachments, I sent off a retinal tear today, and posterior subcapsular cataracts, which are a real disruptive form of cataract, where the light entering the eye is blocked by the bag that the lens sits in, being bound to the lens material, and instead of being nice and clear, it has this obstructive film in the back of it. I often describe it to my patients that it's almost like your toilet window all of a sudden. You don't want people seeing into your toilet window, but if your lens in your eye looks a bit like your toilet window, it makes it hard to see out of your eye, and the vision drops off, and that happens quite quickly. So being more and more short-sighted has a greater risk of that type of cataract forming, instead of the nice gradual oxidation of the lens, which happens more ordinary in late 70s and even through 80s and 90s. There are plenty of, again, rural 90-year-olds with their own lens still seeing exceptionally well. That's why it's important to have regular eye exams. It allows us to detect myopia before it even happens and to put in place tools or advice that can help to prevent it occurring or delay its onset. And as I said there, early detection means that we can delay the onsets and slow the progression and greatly reduce the risk of eye disease and vision loss later in life. So why is it important? That increasing eye growth can lead to serious problems, like what I was talking about needing to refer today, retinal detachments. I was looking at a couple of glaucomas too today. So when we implement some tools to slow down short-sightedness, we also are reducing these risks. Now, this little panel I got from an ability webinar, which is one of our contact lenses, and you'll find it in a lot of resources around short-sightedness, and it's trying to understand the significance of being short-sighted. So the risk of visual impairment when you're 0.5 to 3 is not that statistically different from not being short-sighted, but there's a 3.2 increased risk of having a retinal detachment, and that is quite an undergoing. Even a retinal tear, if someone has a retinal tear, I'm basically ruining their day because they need to go to Christchurch and have boundary laser treatment. If they've got a retinal detachment, not only have I ruined their day, but I've ruined their next fortnight, and potentially longer, because the treatment for a retinal detachment is taking the jelly out of the back of the eye. If you can imagine the eyeball, that big space in the back of the eye behind your iris is filled with the jelly. The surgeon will remove that jelly and they'll fill that space with a gas bubble, which will press the retina back on to its what's called basement membrane, the piece that it's attached to. And the person needs to be 2 weeks with their head down so that the bubble of gas pushes the retina on in place and it can fix in place for about 45 minutes of each hour for 2 weeks, which, yeah, as you can imagine, is quite disruptive. We had a lecturer from Australia who has a lot of resources around dry eyes and contact lenses, Nathan Efron, who was quite short-sighted himself, so he was sort of aware of all these risk factors. And so he volunteered 2 years in a row to, one, have his cataracts operated on, and at the same time have an elective vitrectomy to try and prevent his risk of retinal detachment. I think he might have been in that green and potentially even in that red category. So he knew the risk, and he knew the risk of having this vitrectomy surgery and the cataract surgery, and so 2 Christmases in a row he elected to have a vitrectomy and cataract surgery. And for the first one, he set up some mirrors, lay on the end of his bed and watched the Ashes and the Australian Open. The next year he had it. iPads were around then, and so he hired a massage table and looked through the hole in the massage table to his iPad and again watched the Ashes in the Australian Open. But yeah, that was elective, and he didn't have anything to do over the Christmas period apart from watch sport. But if it's in the middle of carving or the middle of sharing, or needing to do work, 2 weeks off work is not ideal. So that's retinal detachments, which relative to macular degeneration or myopic maculopathy is actually lower risk. So as we said, even though the risk of visual impairment is about the same for that 0.5 to 3, you're still 13 times increased risk of getting macular problems if you're in that low short-sightedness. And then that increases to 73 times higher for someone in that middle bracket, -3 to -4. And as you can see there, absolutely exponential, 846 times above -6. So yeah, that really skyrockets. And as I said, the macula, that's where your fine detailed vision happens. And if half the world are short-sighted, and the majority of those people are in that low amount, that's going to be a lot of people with macular problems, and we may see that risk of visual impairment climb, especially if we're living longer, and there's more chance for damage of the central vision. And yeah, so that 13.6 number that we've got there might transfer to that bottom number, vision impairment, becoming more and more significant. That's not to mention all the people with retinal detachments, all the people who are over that -3 and over that -6 having trouble with their central vision. So you can see why this is a pretty big topic all of a sudden as we enter into the developing world, getting more and more developed and more short-sightedness taking place. How do we track it? So we've installed axial length into our OCT at Ashburton Eyecare, and we get to make these little graphs. We've started a number of people in measuring. I think our youngest at the moment is 11, so they're in sort of this arm here, and we will hopefully see them. What would be really cool is if they crossed over a growth curve. Sorry, I'm doing it the other way. Yeah, it would be cool if they crossed over a growth curve and ended up in a lower percentile. It's a little bit like child growth charts that you're used to in your Plunkett books. And as you can see there, everybody progresses, and everybody at a certain age should be flattening off. Key point there is should. And at the moment, our growth charts are sort of going to about age 17. We're not absolutely flat, and what we are mindful of is as people go through university or through periods of stress, even when they get to become presbyopic and they're focusing in their eye is not working so well, do these things stimulate more eye growth and more short-sightedness, which we definitely see, and does that mean that the risk profile of someone in that sort of category increases? So lots to consider there for us as an optometrist when we're seeing short-sightedness change in a patient. But as you can see from these graphs, the majority of that change is in these adolescent ages, and then the earlier someone has started with short-sightedness, the greater the risk is that they become higher. Each one of these has some margin of error though, so they're not absolute, and the trick is for us as optometrists is to treat you as the individual, and that's where I do all the stats and use all these tools and try to give you the best advice. But no matter where you are, where you start, we know that we can have an influence on the way these eye growths happen with the various interventions. And we know that the lower somebody is, the lower their risk to getting these eye diseases. So no matter where you start and no matter where you end up, if we are making it less than where it would be, then we're reducing the risk. So as we said, we do this in a personal way, and it depends on what you're comfortable with. It also depends a little bit on your prescription. And so this comes from Myopia Profile, so you could use that QR code and jump over to the Myopia Profile. Contact lenses are a wonderful option. They come in daily disposables. Or we have the retainer, which is OrthoKeratology, which is a rigid lens that you sleep in. And yeah, that's another great way. And also, if there's some astigmatism there, we can use OrthoK to change that astigmatism. And yeah, we could also have you some glasses over top of the contact lenses to correct astigmatism, especially if it's not too high. What is really cool in the last few years is glasses have been developed to treat myopia. So if you're not okay with putting your finger in your eye or putting a device into your eye, And that's a good thing to remember about contact lenses, is they are a medical device being put into your eye, and so that's why there's a few more eye exams around somebody with contact lenses, regardless of their prescription. But yeah, if that's not something you're into, we can now do glasses that treat myopia, and they can also include astigmatism, which is really, really cool. And if we're finding that despite our interventions, you're someone who's a fast progressor, so we're still seeing the patient move along those trend lines or faster than those trend lines, there are some other interventions that we can use that don't correct vision but help to correct myopia. And one of those is atropine. Now, atropine traditionally is a really strong way to measure the eye. We'll talk about cycloplegic refractions in this talk, but atropine is sort of the godfather of cyclopentolate. And what it does is it blocks the focusing muscle and blocks the pupil. So if you're using 1% atropine, you wouldn't get any focus up close. It'd pretty much be like being a 60-year-old, and you'd have a big pupil. There's a number of studies out there looking at reduced concentrations of that, and the best one of those is 0.05%, or the strongest effect. There is some effect from 0.02, and especially when used with the likes of OrthoK, there's been shown to be an increasing effect of myopia control by using 0.01. Of course, it becomes an individual thing, and if we're getting a happy level of myopia control of 0.01, well then that might be the case. And it's also a good tool to use if you've started off with 0.05, you've done it for a couple of years, and we're looking at can we wean you off from atropine drops, then we can drop down to 0.02 and then to 0.01, and hopefully we don't get a rebound effect, so we're quickly taking off short-sightedness with that. So here we go, this is what OrthoK looks like. That's on the right-hand side, that's the rigid lens design. These sort of waves that we've got here, that sort of creates a force outwards, and what it does is it flattens the center of the cornea and steepens the periphery part of the cornea. So you get a little bit of steepening in and around this ring. And what that does is projects onto the back of the eye, in front of the back of the eye. It's what's called peripheral defocus. These two contact lenses are daily disposable lenses. MySight uses two lots of rings to project peripheral defocus. Ability also has a peripheral defocus, and then a little area in the middle of that lens that projects +12, so way in front of the back of the eye, and that again is sending a signal for the eye to slow down. Here is the lenses that we use. We are using the Stellist lens. MyoSmart is on the market as well, and there is another Chinese design that is out on the market you may see. They're all giving a clear window for the eye to look through, and then these peripheral defocuses, all with variable designs in the way they do that, but effectively they're providing clear vision so the child can see, and these peripheral defocuses into the eye to stop it from growing, or to slow it from growing. As I talked about, we can use adjunctive therapies. On the right here are those three concentrations of atropine, red cap, because they have an effect on the eye. And then on the left here we have something that's reasonably new. It's a red light therapy that the child looks at twice a day for about 3 minutes, and it's logged on their app. So me as the optometrist get to see how well you're doing during the school days, so 5 days a week. Before school, you'd put in there, sit looking at the red light. Once that session is done, the unit shuts off, so you can't overdose. Child would go to school, and then when they get home from school in the afternoon, once they've done their homework or had a little bit of a break, they go and look at the red light again for another 3 minutes, and that logs in the app that they've been successfully compliant with the treatment. I can check on that, and yeah, then the machine shuts off again, so you can't use it again that day. So that's eye rising, the red light therapy that activates the little battery cells in the retina, the mitochondria. It increases the blood flow, it thickens the surrounding blood vessel layer called the choroid, and that has been shown to slow the eye growth down. So webinar a couple of months back with some of the guys in the North Island, one of whom I used to work with, Tim Eagle at Shatkeys in Hawke's Bay, and then my good friend Jaggarut Lalu at Rose Optometrists in Hamilton. They were talking about how, in combination with OrthoK or with their myopia controlling glasses, on that axial length measure, they were getting no growth. And that's one of the amazing things about this eye rising is having case studies where people are absolutely stopping their eye growth. And it doesn't seem to be that once they've stopped using that eye rise that they get a rapid growth again, which is something that we need to watch out for when we stop doing myopia treatment. Here's Annie again, featuring. Yeah, binocular vision is important. So like I was talking about with excessive near work through university, also I think concussion can have an effect on causing myopia. And then as we get into our 40s and our eyes stop focusing up close so well, the ability as we go through school for our eyes to team together properly and focus together properly is very important. If people have what's called intermediate exotropia, so every now and again one of the eyes shoots out, that is a big risk for more and more short-sightedness. Likewise, if the eyes come together too much, or they are looking at the right spot, but the focus is sort of behind the eye's being a little bit lazy, then that again is a trigger for short-sightedness. So having a good binocular vision workup and addressing any binocular vision dysfunction is really important, especially when someone's not short-sighted when you first see them. By correcting those binocular vision issues, one, it means that reading and learning and being in class and concentration and energy and all those sorts of things are supported, so people have a better time when they're at school or doing work or doing homework and researching. But two, you're delaying that potential onset of short-sightedness and in the long run reducing the amount of short-sightedness that a child ends up with. And like we said at the start, reducing that risk for eye disease later in life. Cool, so at Ashburton Eyecare, we're your child's eye health experts. Obviously, we've always got appointments available. We'll see anyone from age 6 weeks. And if we need to do anything, we can refer them to the pediatric ophthalmology up at the hospital. But yeah, there is so much that we can do in optometry to look after your child, to be proactive in maintaining that child's health. And of course, we've got online booking, and as I've shown there, just search the children's vision testing. If you've got a community services card, then there is funding options available to help subsidise not only the eye exams, but to subsidise the glasses. Unfortunately, it's a little bit with the government right now. It's difficult to get the myopia control fully subsidised, but we can get the single vision lens equivalent subsidised, and it makes those myopia control lenses much more affordable. Just on that, if someone's short-sighted or heading towards short-sightedness, you really do need to be doing the myopia control lenses or some form of intervention. Like I said, we can track this. That would be our absolute advice. But yeah, knowing what we know in optometry and what I've shared today, it is really important to do the utmost you can to mean that in the long run, your child ends up as low in the short-sighted scale as possible and reduce those risks. If you have any questions, flick us email at info@ashi.co.nz, or call the practice. And like I said, we have a number of resources on our website, ashi.co.nz, including this webinar will be up on there if you want to watch it again, and also some articles about myopia and myopia control. We're open 7 days a week, 8:30 to 5 p.m, and we're here in the community within Mid-Canterbury. Thanks for trusting Ashburton Eyecare, and thanks for tuning in to another informative